Evening and welcome to the Cognitive Rampage. I'm your host, Adam Lowery, as usual. I can tell you I'm quite overly excited, as were the message boards and emails coming in, to have Dr. Brodsky here with us talking about bipolar, everything else that you could imagine under the sun. Like I said before, if you have the questions centered around bipolar or anything, technically, psychiatry related, also it was biochemistry is the background.
I had a background in biochemistry prior to going to med school.
Okay. And Canada, right? University of Ottawa is where you were trained at, right?
University of Ottawa is where I did my medical school training, and McGill University is where I did my background in biochemistry.
Yeah, I was trying to tell some of the people that were emailing that I was trying to review the CV that you sent over. I've never seen so many pages of accolades and accreditations and certifications and articles published. It just got me so excited, to have you on the show. And if we want, we can kind of dive right in.
You can't really judge a book by its cover.
I've been telling that to people for a long time about me, forever. That's the faulty attempt at humor, man. So I know I have a lot of viewers watching that are probably interested in waiting, but what got you into maybe even psychiatry to begin with? I mean, what started Dr. Brodsky's journey to where you are now?
Well, I went into medicine first. Loved most of medicine. Actually, mourned a little the loss of my being involved in physical medicine per se, but we were at an age where I couldn't make it as a family practice doctor because jack of all trades and master of none. Things had become so specialized. I saw psychiatry moving into the mainstream of medicine. So I think that, plus a couple of my teachers, probably had a tremendous influence on my going into psychiatry. I can tell you that when I finished my rotating internship and I was up on the psychiatric unit for my first day of residency, one of the hotshot surgeons spotted me, Norm Bolton, and he said, "Lou, my God, you were a good intern." The whole idea being there was a time when people going into psychiatry were viewed as those docs that were afraid of blood, that didn't want to get their hands sullied, whatever.
I didn't know.
But that was not the case in my case. I had to make a struggle to make the choice.
What was as it got you into it? I understand that difference, that stigma that exists among maybe medical doctors that say chose psychiatry. You mentioned kind of a emergence of psychiatry in a certain year. What era was that? When did that begin to happen, and why did that begin to happen?
I finished, I got my M.D. degree in 1967. I was 24 years of age at that time. I hope there aren't too many mathematicians who are watching this.
It just speaks to the wisdom, my brother.
In any case, it was a struggle because I was offered residency training in OBGYN, internal medicine, surgery. I love them all. But I also recognized that psychiatry had been in the realm of witchcraft up until beginning probably around the 50s. And I felt that there was room for a real physician to make it in psychiatry. I remember that when I was in med school, all the myths that I had been exposed to, I remember one in particular. They were presenting a case in med school, grand rounds in pediatrics, on autism. And the physician, who was the head of the department at the time, pediatrics, at the University where I was trained, was presenting the case. The father of the child and the child were in the room at the same time, and he was talking about the fact that autism was created by virtue of parents that were cold, unfeeling, and unresponsive. Now, I'm watching this presentation.
What year was this?
This was probably 1966.
That's why you meant with the witchcraft correlation, is that
Yes.
the fact that autism is from parents treating their child poorly.
Yes. And I remember raising my hand afterwards because the father was sobbing his eyes out as this guy is talking about him being cold and unfeeling. I said, "Excuse me, did you pay any attention to the father of the child?" I said, "Right now, there's only one cold, unfeeling person in this room, and it's you, sir." That was the kind of experience that probably helped push me over.
Witnessing that change, or the need for the change, as far
Obviously a need for the change, because it was ridiculous to even assume that it would be created, that some kid would be that sick. I mean, you could dunk a kid in ice cold water, you could do every kind of imaginable damage to a child.
What's some of the craziest things they were doing back then to treat, say, schizophrenia or something?
Well, they treated, everyone got a shot at shock treatment, for example, which was, again, very primitive.
Now, they still do that today. They still do shock treatment for depression.
For depression.
Right. What is that real? What is that?
It does work.
It does.
It does work with major depression, but you've got to be careful about selecting out which major depression. Is it major depression unipolar type, or is it major depression bipolar type?
All right. So I don't want to cut you off there, but I know you and I could talk unipolar, bipolar, but I know there's a lot of people watching that may have lost us there, and that notion. I know you're about to answer the question. Go ahead, and we'll go back and cover more of that for them.
Well,
So deciding which depression it is to treat.
your standard major depression, as it's understood, can be treated with traditional antidepressants. Patients get better and they stay better. Now, whether or not they have to stay on the medicine indefinitely or whether they stay on it for length of time will vary from case to case. But they will always respond, and they will not typically stop responding to the medication. The same approach to treating bipolar needs to be the approach that is used to treat seizures. And by and large, most of the what I call bioelectric modulators, they're mood stabilizers that do two services. They're used for seizures, they're used for bipolar illness. Are anticonvulsants, all right? Now, creating a seizure in somebody who has a cyclic mood disorder may get a very rapid, dramatic response, but it won't last.
So it has effects, positive effects. What's the length of time possibly?
Well, it may last days, it may even last a few weeks, but it's not going to last. And in the long run, it's going to kindle the process of cycling, which is made progressively worse when they're treated with ECT, when they're treated with traditional antidepressants. So that's where it becomes an issue.
And you know, we spoke earlier about that need to be able to separate that difference between diagnosing bipolar and separating the depression from bipolar and mixing those two. Because I think you were talking about if you treat bipolar as if it's depression, you can have some serious maladaptive reactions. Treating those, because they're both to be treated differently, although diagnosed similarly.
The depression that you will see with somebody who has a true bipolar, in the old days manic depressive illness, they can look the same. So you need a longitudinal study to be able to carve out the difference. Your unipolar depression just has episodes of depression. They will respond not quickly, not dramatically, and not to tiny doses, or what I call homeopathic doses of antidepressants, but they will respond, and they will stay responding as long as they're maintaining the medicine. And I mean, there are ways of deciding whether or not they come off, and if they come off, do they stay off, based on how long they stay better. Okay.
When did the emergence of bipolar start to happen? When was it? When did it go from the person has mood swings to there's a biological or mental health implication here?
First of all, in the old days, a lot of people were using psychotropic drugs in a catch-as-catch-can fashion. Yeah, so let's give them a little bit of this, a little bit of that, and see what happens.
Now, there's some that still do that today. They're running cocktails of 16 or so.
But they shouldn't be. In other words, diagnosis, for prognosis, and treatment. That model has to be maintained.
How do they go outside of that model today?
You mean why?
Yeah, why? Yeah, why? I guess why or how.
For the same reason, for example, that back in the 60s and 70s, they treated all psychotic patients. In this country, for the most part, the vast majority were treated as though they were schizophrenic. Easier. Generic treatment, antipsychotic drugs, that's it. Some of the antipsychotic drugs would make a bipolar worse.
So that then would show the implication of needing to separate depression from actual bipolar disorder. Because if you treated MDD, or depression, or typical depression disorder of some kind, NOS, whatever, with antidepressants, but the patient is really bipolar.
That took a long time to get accepted.
Wow. When did that start to know? When did we start to know?
Probably some of the first articles on not using antidepressants, traditional antidepressants. Do you remember the Geraldo and Phil Donahue shows? Prozac Made Me Do It.
Yeah, I do.
That was in the 80s. That came about because inadvertently some bipolars were put on Prozac and became manic and cycled. And if you listened to the stories told by some of those people, you realize what happened. But it took a while before that became accepted.
How long? Was it 20, 30 years?
I think there's still some people that believe that at the time that a bipolar patient is depressed, he can be treated with antidepressants.
And what might that do if someone who's bipolar is depressed is treated with antidepressants?
Okay, first of all, they'll typically, although briefly, they will respond. And then one or two bad things will happen. Sometimes both. Become manic and then crash, or just start rapid cycling. But the long term is not good. And I believe that a lot of rapid cyclers today, and the definition, by the way, of rapid cycling is only 4 distinct changes in mood in the course of a year, 4 or more. There are some very rapid cyclers, and many of them have been iatrogenically caused, doctor caused, by being treated, I think, improperly.
Holy Lou! So we're creating, holy shit! So, and how much is that due to the fact of this churn medical treatment of, I got to see as many patients as I can, they get the basic criteria?
That started before.
Yeah? Is it because maybe a denial of the existence of bipolar?
It's easier to put somebody who's depressed on an antidepressant than pay attention to what's been going on one of the true giants, and there were a lot of phony giants in the area of bipolar, but Bob Post created the whole timeline to look at historically people who were bipolar. It made a lot of sense. What have they been like over a period of months, even years? And when you begin to get a feel for the cycles, now there are, bipolar illness is not one illness. It's probably a group of illnesses that have a few common denominators. And it's probably as valid to psychiatry as congestive heart failure would be to medicine.
Oh!
Multi-factorial etiologies, in other words, more than one etiology, more than one pathway, if you will, more than one chemical messenger involved, more than one set of distorted genes, but it is as valid a concept of illness in psychiatry as congestive failure. Congestive failure can be caused by arteriosclerotic heart disease, rheumatic heart disease, primary myocardiopathies. But there are a few common denominators about what you do when somebody's in congestive failure.
Right.
Same thing applies to bipolar.
Okay, so that kind of creates the sort of universal treatment. What separates and how does a practitioner get beyond the cookie-cutter approach to get deeper into the individual?
Well, I think the important separation that has to take place now is separating out bipolar from unipolar. Down the road, based on our understanding of genes and our mapping of genes, we may even be able to find specifically the mood stabilizer that will work with this particular patient. Whereas right now, it's still pick and choose. You try this, that doesn't work, there's an alternative, you know.
Right, which can lead to some problems. I mean,
course.
if a psychiatrist is just throwing basic stuff and just working the cookie cutter, that possibly could be the doctors who are creating the problems.
Well, the big problems are created by the doctors, I think, the doctors that are treating the bipolar depression as a unipolar depression.
Now, what? And
now, make no mistake, I've made that mistake. If I have somebody that I think has a true unipolar depression,
which is just depression for those watching,
and I have inadvertently put them on an antidepressant, and 3 days after I get a phone call, "Doc, you did great. It's wonderful. I feel wonderful." I know I really screwed up.
So when you get that immediate return,
that kind of return,
spike,
particularly when I start people out on antidepressants, I will start them out on smaller doses.
Just to work it up.
Exactly. Then I know that and can you imagine what it's like to tell somebody who's feeling better than they have in years,
oh no,
that I'm actually pulling back on this because
you'll never see him again in your office.
It can create a problem, no question.
Because you're trying to tell someone who's manic that you're really not okay, and that's one of the most difficult tasks to do as a practitioner.
Exactly.
Is to prove you're in a manic state, because that can cause someone to feel godlike.
Well, remember, there are two types of manic states. There's the euphoric one, where people like to be, and there's the dysphoric one, where you will automatically have the cooperation of the patient. The dysphoric one is the agitated state, the paranoid state, the state where if somebody looks at them the wrong way, they'll bite their head off. They'll get into arguments. That's not a comfortable position. The euphoric state, hell, you have something in the realm of an illness that's producing what a lot of coke will do only for a short period of time.
Right, just by treating it with the antidepressant.
Yes.
Getting that same stimulant reaction.
Yes.
And can that create an addiction to that type of medication?
Not so much. It's not truly addicting, but it's not going to last, and it's going to make the illness worse.
So possibly someone that may have been diagnosed bipolar, who seems for years and years nothing's changed, that they maybe have begun to rapid cycle even more, or may have been, what you're saying, maybe being treated as unipolar, as depression, when truly, if they're still, feeling that phase or cycling, that really it's bipolar.
From the time a person first experiences symptoms of bipolar illness to the time that they're effectively diagnosed is somewhere around 9-10 years, as a rule. That's the average. So, from the time they begin to experience the illness clinically to the time they actually wind up being properly diagnosed. And by the way, properly diagnosed still doesn't necessarily guarantee proper treatment.
Because there's no...
Because I've seen doctors who have made the accurate diagnosis of bipolar illness still using therapeutic doses of antidepressants.
Still.
And there was a time, because there was a time when we were taught, use it during the time that they're depressed and then pull back on it. Anybody with any kind of observation realized that the cycles became shorter and shorter and more intense. And it wasn't until the 2000s that there began to appear publications talking about this very issue.
Because it's relatively new, and people that aren't well informed you talk to, there's still almost people that would say bipolar is not even real, that it's just life, or it's just natural. How would you answer the person that would tell you that, hey, life happens and we all have mood swings up and down?
It's a question of degree.
Okay.
It's a question of degree. Sure, we have changes in mood swings, most of the time varying based on the experiences that we have. You get a raise, you get a promotion, you're happy, you get fired from your job, your loved one decides to leave you, you're depressed. Yes, that's part of normal mood changes. But mood changes can become much more severe. Depression that's lasting for a long period of time, beyond the period of time you would expect mourning, or a manic or hypomanic state where people are making lifetime decisions based on impulse. It's a whole different ballgame.
Give an example. What may that be for someone? Painting their house at 3 a.m.?
Well, painting their house at 3 a.m. may not be that terribly destructive, other than the effect that it has on sleep. But
which I definitely want to get into with you. What's your example?
Dropping everything that you have and moving out to California.
Running away in a relationship, that kind of thing.
Exactly. A lot of the adventurers, and that's probably why some of the people that settled this continent were probably bipolar. And they carry their genes with them.
So really, the emergence of bipolar has been over the last 30 years, essentially.
The emergence of the concept.
The notion of it, right.
I mean, we had some kind of an understanding of manic depressive illness, but typically, in the old days, manic depressive illness was viewed as people are manic in a euphoric sense, depressed. They did not view mixed states. They did not view rapid cycling. So, yeah, it's evolved.
I've noticed, kind of a cocktail, if you will, a perfect storm of those that I know experience bipolar or have them their whole life. But first, probably a two-part here is, how early can we deem something or someone dealing with bipolar? What are some of the base criterias from childhood, adolescent, teen development? Is it a diagnosable teen disorder?
Years ago, the book said you can't make a diagnosis of manic depressive illness in childhood. They were wrong.
Mm-hmm.
You sure as hell can.
And the precursors for MDD for childhood would be what? Isn't it like it's what, 2 weeks to 6 months severity levels?
Now, if you're talking about major depressive illness, I have some issues with this because I think in childhood and in adolescence, if you make a diagnosis of a major depressive disorder,
mm-hmm.
it's bipolar until proven otherwise.
Oh, elaborate.
Because to be a true unipolar depression in that age group, you'd be in the toenail of the distribution curve. So just on the basis of probability alone, it's bipolar.
Wow.
Do you understand?
Yes. So how many adolescents and teens are... Oh, whoa. So this speaks to the first thing we just spoke about, is if we're treating bipolar with antidepressants. And that's what you see now, is these kids being diagnosed as depressed and being hit with antidepressants. Holy shit. And they could really be, it's bipolar until proven otherwise.
Do you know how many kids I saw admitted to the hospital where I was doing my residency who had been treated for depression and were manic, and the mania obviously had been induced by the antidepressant.
Mm-hmm.
Depending on the later on, as I became more familiar with this, depending on how long it took to wash out
mm-hmm.
the antidepressant, Prozac has a very long half-life and one of its active metabolites, and you're looking at 30 to 36 days to wash out.
That was going to lead to a question. Is that for most SSRIs or antidepressants?
No, that's specifically, Prozac is the longest.
So really, if someone tries the wrong SSRI or antidepressant for, say, a couple weeks and nothing happens, or, I'm sorry, a couple months, like you'd need to for something to kick in, for that to go back to baseline, how long would that take them?
Depending on which antidepressant was selected.
And you said the longest was Prozac.
Prozac has a long half-life. Zoloft, as an example, has a relatively short half-life.
Like?
The half-life of Zoloft is probably about 12 hours, maybe.
Oh, okay.
So, multiply by 6 what the half-life is, and you've got your washout time. You're looking at roughly 6 days is the half-life of Prozac.
Mm-hmm.
30 to 36 days is the washout time.
Well, I'm confused just talking about one pill here. So, what's the purpose of the cocktails? The 16 pills, the 17 pills? What's the notion here?
Well, it depends on what they're trying to treat.
Let's say bipolar.
All right. There are going to be several. You know, the prototype of all the mood stabilizers was lithium. And some of the experimental work was done in Australia. Late 40s. Didn't come into existence in this country until the early 70s, but was used in Canada in the 60s. That was lithium. Since lithium, there have been most of the mood stabilizers that have come on the horizon were anticonvulsants.
Now, why does an anticonvulsant medication work for treating bipolar?
It quiets things down. It settles it down. In other words, there are some common denominators between people who have seizures and people who are bipolar.
Oh, wow. What are the links here? You keep feeding me, so I keep following the
I
breadcrumbs.
can't answer that question.
We don't know yet.
That's right. But I know that there is.
How do you know that?
By what I've seen with people.
Just the hypothesis being made. So kind of that's the new frontier of psychiatry, it sounds like.
Without question, that's one of the new frontiers. But we've come a long way in the fact that we now have specific items that do specific things, and we have conceptual models to at least in part explain why. They talk about a serotonin reuptake inhibitor for Prozac.
Mm-hmm.
That's one of the things it does. Inhibits the reuptake of serotonin.
Right.
That's not how it works. So it's a model to explain, to help us identify the different groups of drugs, but that is not how. Because it takes too much time for the serotonin reuptake inhibitor that is already working as an SSRI for the full effect to kick in. So it's further upstream, but more specific than that, we're not yet. We will eventually be, and as I said, eventually we'll be able to even select the drug, I believe, for the particular individual, recognizing there's not just one illness.
That there's multiple levels of bipolar.
A group of illnesses. You know, in the old days, they thought that 25% of all major depression was bipolar, and 75% was unipolar. My hunch is that it's probably closer to the reverse.
More 75% bipolar and 25%.
That's what I suspect. I don't have any documentation to prove that. I'm just telling you.
Now, has there been, as maybe this has just been a consistent, the 75% being bipolar, is this consistent over time and we're just now realizing it because we're understanding the etiology of it, etc., the symptoms, or could something be causing an increase of bipolar diagnosis, etc.?
This country, back in the 50s, tended to overdiagnose schizophrenia. Europe tended to overdiagnose manic depression. So I think going along with the times, many manic depressive patients were treated as schizophrenics in this country.
And we're talking, what era is this?
40s, 50s.
So that beginning with these, oh wow. So the implications again then, what if we are treating bipolar, or treating someone who has bipolar as if they have schizophrenia? What are the implications here?
Well, the implications is you don't treat the illness, you don't get the mood disorder under control. All you're doing is trying to hit psychotic symptoms and try to modify their behavior. Remember, the first generation antipsychotics, Thorazine, Stelazine, Meloril, people walking around shuffling gait and walking around like zombies.
That's right. Yeah, I mean, I think a lot of people in their mind still have that perception.
Yep.
You know, when they hear schizophrenia, they're very unaware, even bipolar, very unaware of what people deal with on a regular basis.
Many of the symptoms that were attributed to schizophrenia really would have been more appropriately attributed to the medications they were getting for treatment.
So how much of this is really an art form, man?
An art form? No, as I said, I think we are now beginning to move where medically based evidence leads to a lot of the treatments that are evolving, okay?
Okay.
Not just trial and error, not just...
That the guinea pig SSRI rotation.
Exactly.
How do we get by that?
Well...
I mean, the genetic testing you talked about.
Well, no, I mean, drugs are tested, double-blind, placebo-controlled studies. In this country, they're married to double-blind, placebo-controlled studies.
They definitely are. They are.
If it doesn't pass muster, it won't be accepted. There are other ways of achieving evidence that something works without relying strictly on that.
Well,
I remember at a conference, this was years ago, they said, you know, there are only 2 countries in the world that insist on double-blind, placebo-controlled studies. America and Nazi Germany. Oh, I was almost lynched on my way out of it.
But so really, Germany and the United States are the only 2 main countries?
Then.
Oh, then. Okay, then.
But there are a lot of studies that don't utilize mandatorily, mandate a double-blind, placebo-controlled study.
Yeah, what is that? I've been getting
I think there's some issues with placebo control, because I think with some illnesses, the longer you withhold specific treatment, more of a downhill course.
Like dementia.
Like dementia. And can you imagine taking somebody who's just hitting dementia, wants to get involved in the study, and he gets a placebo instead, and there's no making up for the time that he's lost being on a placebo. That, I think, is inhuman.
So people
you want to give him one of the older medicines instead that does do some good.
So you can at least say you're treating someone who came there for a study to be treated.
That's correct. But to leave him with nothing, to me, is inhuman.
And they brag about these double-blind placebos all the time.
I understand that. But that's where I had an issue with that.
You should. I do now, too. I do now, too. So people signing up in desperate need of some sort of treatment and looking for help sign up for these things and take placebo pills and never even get treated.
That's correct.
Man. Well, I've been fielding tons of questions here. So one of them I got was, how would you treat someone that's been experiencing bipolar most of their life that's just not stable and they can't find the right way?
Let me tell you about the first case that I ever treated of an atypical manic depressive, because at that time bipolar, the term, had not been coined. I was consulted with regards to a lady who was the wife of one of the executives of one of the major motor companies, right? She had been admitted to the hospital in a year and a half duration over 50 times. She had been treated with ECT, every conceivable antidepressant at the time, antipsychotic meds, everything.
Yeah.
Now, her illness was interesting because she would have periods of significant depression and also periods of being very agitated and paranoid. She did not have euphoric manic states. She had dysphoric manic states and mixed states.
Explain that difference just for some people watching, the euphoric and dysphoric states.
The euphoric, I'm on top of the world. The world is my oyster. I can do anything, everything. I'm God, you know. Okay. The dysphoric, what are you looking at me like that for? I'll fight you at the drop of a hat. You follow the difference? Okay. The euphoric one, obviously, is going to be much more pleasurable to the person suffering it than the dysphoric one. In any case, her husband loved her. And when she would become agitated, either in a mixed state or her dysphoric manic state, she was ready to leave him. He was actually drinking himself to death at the time, but he really adored her. Other times she'd be super depressed. In any case, I was consulted as a treatment-resistant depression. Those were the terms used. This was a friend of mine, a colleague of mine, who, after I saw her, asked me what I thought. And I said, by the way, I think this is a variation of manic depressive illness. And he laughed at me. And I said, well, hotshot, with the 50-plus admissions over the last year and a half, you haven't done so well, so humor me. That was basically the approach I took. I took her off of every antidepressant. I put her on lithium. It took about 9 months before all of her cycles had really stopped, and she stabilized at maybe a -3. Still some depression, but no cycling. At that point, because I only had one mood stabilizer available, that was lithium, I added a homeopathic dose of one of the first generation antidepressants.
Which one?
Imipramine, tofranil, 25 milligrams. And I was tracking her moods over a period of time, so that if I got into anything where it showed a rapid changes, I would have taken her off. Gradually, over a period of 3-4 months, I saw the mood rise and then stabilize. That was the medicine that she was on when I moved from Michigan to Florida, and what she continued to be on. She and her husband would pay me visits once a year just to say hi, and I think to some extent out of gratitude. When her daughter became
It's life-changing.
when her daughter became ill, they didn't have to mess around. She was put on mood stabilizer, and no problem since. So if that gives you an idea.
Yeah,
That was my induction into it. I'm not exactly sure why I came up with that, but it looked to me like just a variation of a manic depressive illness.
Just to slide off, and you were able to pull that out.
Yes.
oh my gosh, Lou. What are the symptoms of true bipolar? What is the most effective treatment for rapid cycles?
Again, no antidepressants.
No antidepressants whatsoever.
Use mood stabilizers and patience. So that, I mean, the whole idea, and I know that we're living in a society where people want immediate results. Unfortunately, if you're impatient with this, you can do more harm than good.
Because you rush to all the things we talked about earlier.
Or you rush to making changes. And any one of those changes done rapidly or dramatically can turn on the switch for cycling. I'll give you an example. Lithium. Lithium was the very first mood stabilizer available. A lot of people who responded well to lithium would come off of it once they were stable. Hell, I don't need it anymore, right?
Mm-hmm.
Of course, they did need it. They were well because they were on